So today we will continue our topic of stroke. In previous video we discussed about signs and symptoms of stroke. Now today we will discuss about diagnosis. So diagnosis can be done based on history and examination, imaging, laboratory workup and other studies. Now coming to history and examination, one must know the exact time and pattern of symptom onset. Like for example, an abrupt onset with worsening symptoms and decreasing level of consciousness, it is suggestive of cerebral hemorrhage. And if patient says he experienced very severe and worst headache of his life, one must think of subarachnoid hemorrhage. This particular type of headache in subarachnoid hemorrhage, it is also known as thunderclap headache, as it reaches maximum intensity within seconds to minutes. Then we should inquire about patient's history. Here it is important to know any past episodes of TIAs, head trauma, presence of major or minor risk factors, medication, any pertinent family history, and recent alterations in patient's function. Then proper clinical examination of patient is very important to rule out the conditions which mimic the stroke. Like for example, subdural hematoma, cerebral abscess, intracranial tumors, etc. Next, coming to imaging, it is very important to do immediate CT scan to rule out hemorrhagic stroke. The best thing about CT scan is that it is having 89% of sensitivity and 100% specificity in diagnosing hemorrhagic stroke in emergency settings. Then MRI is another imaging modality which allows detection of cerebral ischemia as early as 30 minutes after vascular occlusion, and it can detect infarction within 2 to 6 hours. It has sensitivity of 83% and specificity of 98% in diagnosing ischemic stroke in emergency settings. Then another option is angiography. It may be CT angiography, magnetic resonance angiography, or DSA, digital subtraction angiography. In CT angiography and DSA, the special dye is injected as a contrast. Whereas in case of magnetic resonance angiography, a special technique called time of flight or TOF angiography is used, which is dependent on flowing blood, and therefore it is non-invasive in nature, and hence there is lower risk of stroke compared to other invasive techniques. Then another valuable investigation is ultrasound Doppler. It may be transcranial Doppler for examining the posterior circulation, or it may be carotid Doppler for examining carotid arteries, or we can say anterior circulation. Then echocardiography should be done to rule out cardiac embolic source, and CT or MRI venography can be done if venous thrombosis is suspected cause of stroke. Then next is laboratory workup and other studies. Here some important tests are complete blood count, blood glucose, lipid profile, ESR, then VDRL can be done for neurosyphilis, then ECG and Holter monitoring to rule out cardiac arrhythmias, prothrombin time and partial thromboplastin time to rule out coagulation disorders, and then last but not least, the blood culture should be done if endocarditis is suspected. Then coming to prevention, we already discussed this in transient ischemic attack, so please watch my previous video on TIA to know more about prevention of stroke. Now let's discuss about management. Here it is important to remember that time is brain. Any typical patient who has experienced stroke loses 1.9 million neurons, or we can say 14 billion synapses every minute until the stroke is completed. So the earlier the condition is managed, the better will be the prognosis. Before we proceed to management, let's discuss about the goals which we need to achieve. So important goals are that we need to improve cerebral perfusion, we need to maintain adequate blood pressure and sufficient cardiac output, restore or maintain fluid and electrolyte balance, maintain blood glucose levels, control seizures and infections if any, then control edema, intracranial pressure and herniation. Also, it is important to maintain bladder and bowel function, maintain integrity of skin and joints, and prevent complications like DVT, aspirations, decubitus ulcers, etc. Now, stroke can be managed pharmacologically, neurosurgically, or by rehabilitation. So let's begin with pharmacological management. Here, immediately intravenous thrombolytic therapy should be started within first 3 hours with intravenous recombinant tissue plasminogen activator 0.9 milligrams per kg up to maximum of 90 milligram. Out of this, 10% should be given as bolus over 1 minute and remainder over 1 hour. It is important to know that this treatment should be initiated only if there is no evidence of hemorrhage on CT scan and no other contraindications are present. Like these contraindications, they include any recent hemorrhage, uncertainty about the time of onset, if the patient is improving spontaneously, or any head injury or previous stroke within past 3 months, if there is gastrointestinal surgery in last 21 days, or if the blood pressure is more than 180 by 110 millimeter of mercury, or if the patient is on anticoagulant therapy or having any seizure. If any of these contraindications are present, then intravenous thrombolytic therapy should be avoided. And if the patient is not eligible for thrombolysis, then administer aspirin 300 milligrams daily for 2 weeks. In case if the patient is aspirin intolerant, then clopidogrel can be given instead. And head elevation should be done and mannitol should be given if there is any elevated intracranial pressure. Here it is important to note that any attempts to lower blood pressure of hypersensitive patients should be avoided during the acute phase of first 72 hours. However, if the systolic pressure, if it exceeds 220 millimeter of mercury, then it can be lowered up to 170 to 200 millimeter of mercury by using intravenous labetalol or nicardipine. But there should be continuous monitoring. Then after 72 hours, it can be further reduced to less than 140 by 90 millimeter of mercury. Then blood glucose levels should be maintained between 4 to 11 millimoles per liter and oxygen saturation should be maintained over 95%. In case of any risk of aspiration, placement of nasogastric tube should be considered. Urinary catheters, they should be avoided, and if placed, they should be removed within 24 to 48 hours. Now coming to neurosurgical interventions, it is important to repair or resect any superficial ruptured or unruptured aneurysm or arteriovenous malformation. In case of large middle cerebral artery stroke, a small number of patients, they are at risk of developing massive cytotoxic cerebral edema, and this is resistant to medical therapy. This is known as malignant cerebral infarction. In these cases, decompressive hemicraniectomy should be done within first 48 hours and it will be life-saving procedure. In case of large cerebellar infarcts, posterior fossa decompression should be done within 48 hours. And for those patients who are not responding to or not eligible for intravenous thrombolytic therapy, manual thrombectomy can be done by using Mercy retrieval system or penumbra system within first 8 hours. Both these systems, they work on different mechanisms. Like Mercy retrieval system, it retracts and pulls the clot, whereas penumbra system, it aspirates the clot. Then next is rehabilitation. Here I can say the main focus should be on earliest mobilization of patient. Then rehabilitation, it is of three types: restorative, preventive, and compensatory. Restorative, it is aimed at improving impairments, activity limitations, and participation restrictions. Preventive is aimed at minimizing potential complications and indirect impairments, whereas compensatory is aimed at modifying the task, activity, or environment to improve the patient's function. Then last, coming to the phases of rehabilitation, there are three phases. First 72 hours are considered as acute phase. Then subacute phase ranges between 72 hours to 6 months from onset. Whereas chronic phase, it starts from 6 months onwards. Out of these, the acute and subacute phase rehabilitation is critical for patient's recovery. So that's all for today. Thank you. Have a nice day.